I am recording now.
Great.
Okay, back to the beginning. We're going to talk about the techniques for opening airways, controlling bleeding, and treating for shock. We're not going to be able to apply those techniques because we have no hands-on available the way we're teaching the class tonight. We won't be conducting triage, but we're certainly going to talk about triage in detail. You may remember that multi-casualty incidents are those incidents where there's situations where the normal emergency response capabilities are overwhelmed. And that's what CERT's all about, is to help the first responders when they are overwhelmed with casualties. But what you learn in the hands-on classes and what you may be reminded of in this review are techniques that you can apply to any sort of casualty incident that you may witness. The first thing I think of is automobile accidents. We have a lot of automobiles on California, a lot of highways, and in particular, people nowadays are really wanting to get out and go places, and it's a very, very dangerous place to be. And the only time I've ever used any of my first aid training has been an automobile accidents. So just because we may not have something where CERT is mobilized doesn't mean you won't be able to use what you take home tonight and what you've taken home before from the classes. So how do people die from trauma? If there is overwhelming and irreversible damage to vital organs, death can be within minutes, and you may recognize that by coming upon a scene where it's pretty messy. The next thing that can happen is can be an excessive bleeding, and that can happen within minutes. Depends on what vital organs are damaged. Person can look perfectly healthy, but they can die within minutes because of bleeding internally. And then later on, we got to worry about infection. If we're in a CERT situation, we have to really be careful about helping to prevent infection. If we're in an automobile accident situation and we can get advanced medical care there quickly, well, then we may not have to worry about it quite as much as we would in a survival situation. But infection can kill, and it does. Even at times, and you may have heard of instances where people have died even after they've been treated in a hospital. So hospitals can be dangerous. So here's our killers. Airway obstruction. There may be something in the airway. For instance, somebody choking on some food, or it could be a matter of them being unconscious and then being in such a physical position that the tongue is blocking the airway. Excessive bleeding, we've already covered that. And shock. Shock is a killer. I like to think that anytime I come upon a scene where there's been some injuries, I treat for shock, no matter what kind of injuries there may be. So the first thing we're going to do is we're going to size up what's going on, what's happening, how many victims are there, do we have the capabilities do we have the necessary means and the capabilities of handling the situation? And we want to make sure we check the scene for safety. For instance, if you come upon an automobile accident and you're in the far right-hand lane, you pull over to the edge of the road, and the accident is on the number 1 lane, you don't go running across 4 or 5 lanes of traffic without checking for your own safety, because you're going to just add to the confusion if you get hit by an automobile, and you're certainly not going to be able to help anybody. If the victim is conscious, you want to make sure the victim can see you and identify yourself, your name, your training, name of the organization. If you want to say CERT, fine. I don't think anybody's going to recognize what CERT is. You can say, I'm I'm trained in first aid, I'm trained in safety, I can help. And you need to ask for permission if they are mentally able to provide permission. You need to ask for permission to evaluate and actually to be hands-on. Now, let me talk a little bit about hands-on. If the victim cannot provide consent, if they are unconscious, for instance, then the consent for you to touch them, to provide treatment is implied. In other words, you can go ahead and you can provide care. If the victim is a child under 18 years of age, consent must be provided by a parent or guardian. However, if no parent or guardian is available, consent is implied. If life-threatening conditions are present, provide care. Even if a parent or guardian declined to provide consent, if life-threatening conditions are available, you can provide care. For instance, if they're not breathing and you're trained in CPR, you can provide CPR. Now, respecting cultural differences is important. We live in a kind of a multicultural society, in particular right here in California. And I really don't have any great suggestions on how you handle that. If they don't speak English, or if their English is very, very broken, you have to try to speak in very, very simple words. And if you have to use some sort of sign language, you use some sort of sign language. But you have to try your very best to respect the cultural differences. I really don't have any better answers than that. Okay, so we check for breathing. The first thing we're going to check for, we tap the victim on the shoulder. We don't shake them because we may aggravate an injury. We open the airway, and we do that by putting a palm on the forehead, 2 fingers under the chin, and tilt the jaw upward. I'll show you a picture of how to do that. We put our ear over the victim's mouth. Get very, very close as you possibly can, and then look, listen, and feel for breathing. And assert, we evaluate and repeat if necessary. In other words, if we don't detect any breathing by looking, listening, and feeling, we'll then make sure we've done the opening the airway properly. And then we're going to evaluate and look, listen, and feel again. So here's how we do it. The tongue is the only muscle in the human body that is only attached at one end, attached in the back of your throat. Every other muscle you have in your body, in order for it to function, it needs to be attached to at least 2 places. So by doing this head tilt chin lift, we're going to do it this way. By doing this head tilt chin lift, we move the tongue away from the airway, and then we can look, listen, and feel for breathing. We do that for no more than 10 seconds. If there's no breathing within 10 seconds, we don't detect any breathing within 10 seconds, then we check to make sure we've done the head tilt chin lift properly. And then we check for breathing again for no more than 10 seconds. Now, some of you may think, well, this is pretty dangerous because we're moving the head and moving moving the vertebrae in the neck vertebrae, and it could cause damage if could cause further damage if there's already damage to the vertebrae. Well, the thing is, if someone is not breathing, they are going to die. So we take that risk. We do the head tilt chin lift at the risk of causing further damage. Now, it can be done without further damage to the vertebrae. And the vertebrae are actually a lot more stable than what we give them credit for. But we've got to remember that if they aren't breathing, they are sure to die. If we do a head tilt chin lift and we open the airway and they start breathing again, they may end up with some sort of residual damage, but at least they're alive. So keep that in mind. Okay, bleeding. 3 types of blood vessels: arteries, veins, and capillaries. You're not going to bleed to death with capillary bleeding, but you can get infected. Venous bleeding, the blood is flowing. It's a darker color blood because it's returning to the heart for oxygenation. So it's a little bit darker in color. Arterial bleeding, the blood is usually bright red, and it's spurting because it's under pressure. Person can bleed to death much more quickly with arterial bleeding than they can with venous bleeding. Although enough venous bleeding, a person can still bleed to death. And it also depends on how healthy their liver is. The liver is an integral part of the system that creates the cells that allow for blood to coagulate. And if a person is having, for instance, cirrhosis of the liver or has hepatitis, it's possible that a person can bleed more quickly through venous bleeding because they don't have the cells that are necessary for the coagulation of the blood. So we worry about arterial bleeding the most, right? Direct pressure is the most effective way of controlling bleeding. We're not saying that you're going to completely stop all bleeding, but direct pressure can help to control bleeding that is out of control. You can use your hand for direct pressure or pressure bandage. Now this slide shows no tourniquets. You may have been in one of our classes where we were teaching the proper method for using a tourniquet, because we've started teaching the use of tourniquets. However, tourniquets can be dangerous. It's kind of a last resort, and tourniquets have to be applied properly. And you can actually end up losing a limb to save a life. If you use a tourniquet. If you can use a tourniquet properly, if you actually loosen it after a few minutes, loosen it just enough to see whether you're controlling bleeding or not. But if you don't loosen it, you may save a life, but the person may end up losing that limb. Elevating, what that does is it just helps gravity to help to control the bleeding. For instance, if you have bleeding on a hand or a wrist or an arm, if you can elevate that above the heart level, well, then it helps to control bleeding. Pressure points, we haven't taught a whole lot of pressure points. The brachial pressure point is the one that's used to control bleeding in the arm, and that's above the elbow, and it's an artery, the brachial artery, that's located between the bicep and the tricep. And you can actually, if you use 2 fingers on the inside of your arm, you can feel the kind of a valley between those two muscles, and you can feel arteries or an artery, and you would push that against the bone, and that would help to control the bleeding in the lower part of the arm. Femoral artery is much more difficult to reach. It's buried deep in the thigh near the femur, and it requires a great deal of pressure, sometimes 2-handed pressure, in order to reach that pressure point. Diagram shows it pretty well, and you can see it's right up against the upper part of the femur, and you can see a very, very fleshy part of the body. You have to overcome that large muscle that is there to help to protect the artery. The nice thing about the design of the human body is that most of our arteries are buried deep. That's for their protection, and they work pretty well until you get a bad injury or a bad cut.
Mike, I had a quick question on the tourniquets. I was in the last class before the lockdown, and we were told at that point that tourniquets could be used. Is that a change in policy?
What, using a tourniquet?
Yeah.
That is a change in policy, yes. I'm not sure, Jim might be able to help when that came about, but we started teaching that, I guess about a year ago. Is that correct, Jim? Well, Jim's not there. Yeah, it is a change in policy. We now teach tourniquets, and you can use a tourniquet if a life is in danger and you're not able to control the bleeding with direct pressure, elevation, and pressure points.
Mike, I was on mute. Sorry, I didn't jump in. But tourniquets are relatively new to CERT instruction. As Mike said, they were added about a year ago. So I think there were only 2 classes where we did show how to apply a tourniquet.
Right.
If you have not had that instruction, it's very difficult to understand the proper use of a tourniquet unless you do it in a practical example. So, it's very difficult to talk about on the screen tonight. If you would like to learn more, I invite you to attend our next CERT class, whenever that is, when we do disaster medical operations, because we definitely will be explaining tourniquets, and students will have the practical exercise in order to apply it correctly.
Thank you, Jim.
Mhm.
Okay, now if a person has a pressure being applied to a certain portion of the body, I have to choose my words here. If a person, let's say, is in an automobile accident and they're trapped inside the car, and a certain amount of pressure is being applied, which makes it difficult or impossible to remove them from the vehicle, for instance, or they're in a building that's collapsed, and they have portions of the building on their body, various portions of their body, creating a great deal of pressure on the body. It results in ineffective circulation of blood to certain portions of the body because of that pressure. If there is a significant period of time, for instance, 3 hours, 3 or 4 hours of ineffective circulation of blood to a certain portion of the body, well, there is damage to the cells and tissues that are not getting the circulation. And those cells begin to produce toxic, the fluids of the body become toxic. So if in the rescue, that pressure is released after several hours, it's possible that those toxic fluids will be released into the body and create toxicity in the rest of the body. That's one of the reasons why we say, I made that comment about if you use a tourniquet, you may have to risk losing a limb in order to save the life. So if you use a tourniquet, there's always that risk of creating toxicity where the portion of the body, the tourniquet has cut off circulation to that portion of the body. It creates shock in addition to that. And if you have ineffective circulation in any portion of your body, then it's going to create problems that can be deadly. And that's what shock is all about. Not just to one portion of the body, but shock can create ineffective circulation to the entire body. Now, here's some signs of shock. Now, I told you before, my policy is I come upon an incident where somebody is injured, I treat them for shock right away. Get them laying down horizontal at the minimum. Now, the first line there says weak, restless, and irritable. You know, for the past year, we've had a lot of pressure on us, and so I don't know whether that's such a good signal of medical shock. That may just be that you're just pissed off of what's been going on for the last year. Rapid and weak pulse, certainly there's a cause for that, but it may be because a person's under stress. You know, a normal pulse for an adult is 60 to 100 beats. Now, I don't know what your pulse is, but my pulse normally runs around in the low to mid 70s. So if my pulse is 100 beats, well, I may have just been exercising. So that may not be really a good indication. But you need to take in the totality of circumstances. If it's an accident, or they fell off of a bike, or they've fallen off of a height greater than their own height, onto a hard surface. If they are not making sense when they're talking to you, and they have a weak pulse or a rapid pulse, well, then if you take in the totality of circumstances, then it may not have anything to do with the fact that they're under stress. It may be because they've got injury. And that's why I say I always treat people for shock if I come upon any sort of incident where there may be injuries. Rapid shallow breathing, we'll talk about that when we're talking about triage. Pale, cool, moist skin, certainly that's a pretty good indication of some sort of medical stress. Blue lips or fingernails, now that's definitely an indication of bad circulation. Nausea and vomiting. You know, if there's a black Jack Daniels bottle empty then right next to them, that may not be a good indication of any sort of medical emergency. Unconsciousness, drowsiness, dizziness. You got to take in the totality of circumstances. Low blood pressure, you're not going to really know that unless we do a perfusion check, and we're going to talk about that here briefly. So naturally, treat anybody who's unconscious for shock, right? And I don't think it would hurt if you adopted my policy. If you come upon an incident where there may be a medical emergency or maybe somebody's injury, just get them to lie down. I've come across automobile accidents, the person sitting up, they look a little pale and they're holding an arm which may be broken. They're saying, can you help me? I'll just get them to lay down. So how do we treat? Well, we're going to control major bleeding. Well, we're going to do that anyway, right? But if we don't control the major bleeding, well, it's certainly going to lead to shock if it hasn't already started shock. Place in a recovery position. There's a photo there on that slide of recovery position. Since we're not doing any hands-on tonight, if a person is laying on their back, there's a simple way to do that, but it's hard for me to describe how to do that, other than if you are going to try to do that, you need to support the head and neck. And you notice the left hand of that caregiver in that picture is supporting the head and the neck. And you need to roll the person as along the longitudinal axis of their body. Try to keep their back straight. And you use their right leg to keep them from rolling over too far. And you use their right arm under their head to help keep the head in the right position, maintaining kind of a straight line from the top of their head all the way down to their hip. That's what you're after if you're going to have to move somebody. But if you don't have to leave them, then don't move them. Okay, we don't want to move people unnecessarily because we can cause further damage. Now, how do we maintain body temperature? Well, you know, the body loses heat a lot more rapidly through the ground than we do through the air. So I would say if you've only got one way of maintaining body temperature with a jacket or a sleeping bag or something like that, try to carefully place it under the victim rather than on top of the victim. Because one blanket under the victim is going to do at least as much as two blankets on top of the victim. And if we if we have some restrictive clothing to help with circulation, we can loosen restrictive clothing. Okay, we're gonna talk about triage. Triage means to sort, and that's what we're gonna do when we come across multiple victims. We're gonna sort the victims as to who needs immediate care, who needs delayed care, or who can have delayed care, or who probably doesn't need any care at all, and that may be able to help you with their triage. So we do a size up. Remember the earlier slide? We want to make sure that the area is safe for you. You've got the training and you've got the equipment. You don't want to add to the victim pool. You want to be able to provide care. You don't want to be the person who's going to end up needing care. In a couple of weeks, we're going to talk about light search and rescue. So when we talk about conducting voice triage, before we enter any structure that we're going to be searching, we're going to yell out, "We're search and rescue, and then we're here, we're the federal government, we're here to help." That's certainly going to keep everybody quiet because they don't want you helping them, right? So we're going to tell them search and rescue. If you can safely come to my voice, and you wait, listen, and look to see if somebody is going to be able to come to your voice safely. That's a person who is going to have probably minor injuries. Now I don't guarantee that they're going to have minor injuries, but at the time that you conduct the triage, and we try to do triage in about 30 seconds, at that moment, you're going to classify those person as minor, and you're going to send them to somebody or some place because you're still responsible for them. And we'll talk about how you're going to document, how you're going to classify them, and how you're going to document. After we've waited an appropriate period of time for people to come to your voice, then we're going to start our search using a systematic route. We're going to be systematic and thorough. Those are two words that I emphasize when I teach the classroom version of this. And I want you to remember those two words, be systematic and thorough, whether you go to the right or whether you go to the left. Wherever you are, be systematic so you don't have to guess whether you've covered everything you need to cover. You start where you stand, obviously right there at the entrance to or wherever you are, start where you stand. You evaluate each victim as you encounter them. We're going to talk to you how you do that. And then you tag them. That's the way you're going to document it. And that's your documentation, because you're not going to take the time, unless you have a scribe, you got plenty of people that can write everything down. You're going to tag them so that you can, that's your documentation of the number of victims you have and the type of victims you have. Anybody classified as immediate, we're going to go into that in detail. They're the ones who are going to be transported. You're going to call that in. If you've got a radio, you got somebody manning a radio, call in. We encountered somebody who needs immediate attention, and maybe you can get somebody there, but you have to continue on conducting triage. Don't get hung up on trying to provide care when you're doing triage. You're trying to do the most good for the greatest number of people. And you can't do that if the first person that you encounter, you're spending way too much time on. Then maybe the next victim may be bleeding seriously. So we're talking about simple triage and rapid treatment, the START triage system. There's a card that may be used. And there's the colors that we would use. Red for immediate, yellow for delayed, green for minor, and black for the deceased. Okay, and there we go, minor, immediate, delayed, and deceased. So we consider the minor folks walking wounded. We don't know what sort of maybe internal damage. If they don't have they don't have obvious injuries, they're not bleeding seriously, bones sticking out, that sort of thing, they're probably not gonna come walking to your voice. So we classify them as a walking wounded or minor, and we tie green tape around their arm. That's our documentation. They don't require immediate care, and you send them to somebody or someplace because you're still responsible for them. You're still accountable for them. And if they seem pretty healthy, maybe you can use them to care for others as you conduct your triage. Now, the word screamers is in here. The word is that if they're screaming and yelling, well, then there may be not in such a serious condition. That may or may not be true, but it may be an indication that at least there may not be an immediate care. But if they're bleeding seriously and they see that they're bleeding, then they may become a screamer. So immediate folks are the ones who are gonna not pass our RPM, which is respiration, perfusion, and mental status. That's our cue for classifying a person as whether they need immediate or whether they need delayed care. It's gonna tell us whether they have life-threatening injury. Now, if they are unconscious, they are not responding to your voice, then they are automatically classified as immediate because they fail the mental status check. Let me see if I can get to. Okay, here's RPM. R stands for respiration. So if they are unconscious and they're not responsive, we want to check for breathing. So we position the airway the way I showed you in previous slides. Look, listen, and feel for breathing for no more than 10 seconds. If we don't detect breathing, as search, we do the same thing again. Reposition the airway, look, listen, and feel for breathing for no more than 10 seconds. If there's still no breathing, tag the person as deceased, move on to the next person. But if you detect breathing, then you want somehow to maintain an open airway. Now, maybe that person who was classified as minor that's accompanying you, or if you've got enough certs with you, you can leave one cert there to maintain an open airway. Or if you feel confident in placing them into a position where their airway will remain open, and you feel you can do that safely, well, then go ahead and place them in that position. You got to maintain an open airway. You classify them as immediate because they were not responsive, but they are breathing. If they can follow, if they're breathing, then they pass the respiration. You check for perfusion by pressing on the nail bed. You press on the nail bed, and if it becomes pale, and then you release the pressure on the nail bed, and you get circulation in approximately 2 seconds, 2 or 3 seconds, then that passes the perfusion test. If they have nail polish on, press on the heel of the hand. Same thing, that portion that you press on the heel of the hand, that portion of the skin will pale, and then the healthy perfusion, healthy capillary refill, that will turn pink again within 2 to 3 seconds. Then you move on to the next step, which is mental status. Give a simple direction, like show me your hand, or would you come here? Can you step over here? Can you recite the alphabet? Give them some sort of direction. Don't ask them their name, because if their mental status is not adequate, they may be thinking of their pet, they may be thinking of their daughter, their son, their brother, their sister, their aunt, their uncle. So I would say give them some sort of order, give them some sort of direction to follow. And if they pass that mental status, they pass R for respiration, they pass P for perfusion, they pass M for mental status, then they're classified as delayed. If they fail to pass any of RPM, if they fail to pass the respiration, then you don't have to do perfusion or mental status. If they fail to pass perfusion, you don't have to go on to mental status. You classify them as immediate. If they fail any of those steps of RPM, you classify them as immediate, and then you move on.
When you say give them direction, you mean like ask them to touch their nose or ask them to wiggle their index finger or something?
Sure, that sounds good.
Okay.
Or raise your right arm or raise your left arm.
Okay.
Turn your right hand over. Show me wiggle your thumb. Yeah, some sort of direction. They aren't going to do it if it's injured because it's going to hurt. So just if you think that maybe their right arm's injured, well, then don't give them a direction to raise their right arm. They probably aren't going to do it, but give them some sort of direction. It might not hurt as soon as you approach them. They didn't get up and come to the door. You didn't classify them as minor. If their eyes are open and they seem to be aware of what's going on, say, show me your right hand. They show you the right hand. Well, obviously their mental status is good. You can check for perfusion right away, right? And if they aren't panting, then their respiration is good. Remember, the breaths per minute for an adult is about 12 to 18 breaths per minute. For a 3-year-old is 20 to 30. If an adult is panting, they're probably breathing shallowly and it's in excess of 30 breaths per minute. If they're panting, then right away you can classify them as failing the respiration and you don't have to move on. But if they're not panting and you give them the direction, show me your right hand, they pass their mental status. They're not panting, they pass the respiration. All you have to do is check for perfusion. And I've done it before, and it can be, you can do RPM in less than 10 seconds.
Yeah.
If you do it that way. Does that help to answer the question?
Absolutely.
Okay. Let me go back. These slides can be a little confusing, and so I wanted to move on to okay, we were back at this immediate slide. So if an adult has 30 respirations per minute, or if they're unconscious, classified that they fail the R, so you don't have to do perfusion, you don't have to do mental status. The breathing's normal, apparently normal. Perfusion check, they fail a perfusion check, then you classify them as immediate and you don't have to move on. You don't have to check for mental status. So if the capillary refill is 2 seconds, 2 or 3 seconds, then they pass perfusion, then you check for mental status. But you can see, if you approach somebody and they're conscious, you can take care of all 3 of those steps, RPM, very quickly. Okay, so delayed, they pass RPM, they didn't come to the door, so automatically you classify them as delay. Okay, so it's not complicated. They may have broken bones. They may be laying down and unable to move. But if they pass RPM, they didn't come to the door, the only thing left is delayed. Now, if they fail the breathing check, head tilt, chin lift, look, listen, and feel for breathing. Pardon me. You classify them as deceased and you move on. Now remember, at search, we try the head tilt, chin lift twice. And remember, don't be, if you're fearful about damaging the neck, there may be serious damage to the neck vertebrae. Remember, if they're not breathing, they're dead anyway. So at the risk of more damage, you still do the head tilt, chin lift, and you look, listen, and feel for breathing. You may be able to save a life, otherwise they're gonna die for sure. Okay, we talked about this pretty extensively. We gotta make sure the scene is safe for you. Okay, you've got the training. You're gonna provide the life-saving classifications. Check the scene for your own safety. Stop, look, listen, and think. Okay, sometimes that's hard to do under a stressful situation. That's why I really emphasize stop, take a deep breath, gather your thoughts. Okay, and if you've been assigned the task of doing triage in a structure, remember, as search, we don't go into structures that are heavily damaged. And if it looks like it's moderately damaged, you're gonna have to make a decision on whether you're gonna go in or not, okay? What could happen if you have an aftershock, if it's an earthquake situation? Or if there are fires, how bad are the fires? If there's smoke pouring out of there, you know, you need to rethink about what you may want to do. If you can develop a plan of action, it's not going to be very complicated. Okay, you do voice triage, you get the walking wounded out, classify them as minor, start where you enter, make sure you're systematic and thorough, and use RPM to evaluate and tag each victim. Remember the tape, the plastic tape, that's
Yep.
what we use for documentation. So make sure you pull off a decent sized piece of tape before you tie it around the victim's arm. Don't try to pull it off the victim's arm. You know, we don't want to cause further damage. So pull out a long piece, pull off a piece, put it in a safety pocket, then tie it around the victim. So red tape for the immediates, yellow tape for the delayed, green tape for the minors, black tape for the deceased. Okay, that's our documentation. So be careful with that, because when you come out of conducting your triage, you may have to provide documentation to the rescuers that are going to go in.
Right.
And you're going to want to make sure that they know how many people they're going to look for, how many immediates they're going to look for, and how many delays they're going to look for. Don't waste their time by fouling up your documentation with the tape. Okay, here's some of our pitfalls. We've already gone over the plan. Okay, this is our plan. We've already gone over that. Got to make sure you got some sort of plan. Not that complicated. Set up teams of 2. You got to get somebody's got to take charge and come up with this plan, and make sure that the people who are going to be doing the triage understand the triage. The problem that we have in our exercises is that the triage team spends way too much time engaging the victims in conversation. We've got to stick with RPM. RPM is your friend. That helps you make the decisions. Don't make it personal. Don't make it complicated. Now, even that person who you classified as minor, if they've got a head injury, it may be they may become comatose while they're sitting out there underneath the shade of a tree under the care of another CERT person. But at the time that you classified them, they were classified as minors. Not your fault if they become comatose or they even become deceased because of head injuries, for instance, or internal injuries. that you've got to, you can't get personally involved. You've got to let RPM be your friend. Don't focus on an injury. For instance, you could have a young child who's had a traumatic amputation of the arm, but they pass RPM. You think, well, no, they can't pass RPM, but they do in fact pass RPM. And you want to classify them as immediate. Well, I'll tell you, you can go ahead and classify them as immediate. Nobody's going to fire you. Nobody's going to dock your pay. But let RPM be your friend. Let RPM make the decision for you. Don't make it difficult on yourself. Don't be providing treatment. If you've got enough CERT people, you've got 2 people doing triage, you've got 2 people with first aid equipment with them, well, then let the other two people that are there that aren't doing triage, let them take care of the immediate. Or maybe you can call and you can get a team in to start transporting the immediate, or maybe even care for the immediate. Okay, here's our summary. Everybody remember what the killers are, right? Bleeding, breathing, the infection. And I talked to you about approaching a victim. You have to get consent before you touch the victim. And for those under 18 years of age, you've got to get consent by a parent or guardian, but you don't have to get consent if you have life-threatening conditions. And if no parent or guardian, no matter what sort of conditions there are, consent is implied. If a person is unconscious or an adult is unconscious, consent is implied. You know how to open the airway? Head tilt, chin lift. Look, listen, and feel. Get your ears close to their nose and mouth as you possibly can. Look, listen, and feel for breathing for no more than 10 seconds. Open that airway again. Make sure you've done it right. Control bleeding. Direct pressure. Direct pressure works very well. Recently, I was involved with somebody who had very, very low platelet level in their body. And they had a nosebleed, and they couldn't control the nosebleed. The nose was bleeding in the hospital from about 8 o'clock in the evening one night until 3 o'clock the next afternoon.
Wow.
Until she had 2 infusions of platelets and of blood. And the only way that they eventually controlled the bleeding was placing a special device way up into the nasal cavity, which was very painful. And then they inflated that device that created pressure on the blood vessels in the nose that were bleeding. Eventually, the bleeding stopped because the platelet level began to come up. But they stopped the bleeding by direct pressure. We want to treat for shock. I suggest you take you use my attitude. Any sort of injury, any sort of injury where there may be any sort of situation where there may be injuries, falling onto a hard surface, treat for shock anyway. Get a person at least horizontal. We talked about size up, make it safe for you, get a little bit of organization, make sure you know how to do triage, and use RPM. RPM is your friend. Let RPM take the emotion out of what you're doing, because it's going to be very, very difficult not to engage these victims in conversation. Okay, any questions? Sorry I haven't taught a class for more than a year, and I'm not very smooth, and I apologize. I appreciate your patience with me. Questions? No questions?
Nope, I've got a comment, Mike.
Okay.
I'd like to touch on a couple items. The introduction of a tourniquet was not introduced into the CERT curriculum, but maybe a year and a half ago, and I think that we have just taught it in 2 different classes. So my advice to those that are listening in here is if you have not been instructed and not practiced how to apply a tourniquet, please do not use it. Number two is if you have been instructed and perhaps you've attended one of the last two classes, then remember, you can't take the tourniquet off once you apply it. That is the removing of the tourniquet is done by a medical professional only. Okay, Mike touched briefly on the triage colors. We don't have the cards, but we do have triage tape. So it's the red for immediate, yellow for delayed, and green for minor. A little comment on shock. Not too long ago, I was working on a table saw, and I did a nice fillet of one of my fingers.
Oh.
Fortunately, it wasn't a bad fillet, but in any case, me being a wuss, I immediately felt like I was going into shock. So I want to underscore the fact that, you know, shock can happen for minor injuries just as well as major injuries also. So don't overlook that fact. All right. So again, we'll last call for questions.
I just have one question. Since both my husband and I are on blood thinners, what impact does that have in trying to stop bleeding? I mean, do you find it much harder if you don't know if the person is on blood thinners or not? They're bleeding profusely. Have you ever seen an impact? Does it make it harder to stop the bleeding, or?
Mike, do you want to handle that one?
I'm sorry. I didn't really understand the question. Jim, could you repeat the question?
Sure. Say a person is on blood thinners where, you know, obviously the medication thins the blood, and a person has a serious cut and they're bleeding profusely. What methods would you use to stop the bleeding?
We always use direct pressure. If you can locate the pressure point, the brachial pressure point, if it's in the lower part of the arm, then you can use that. But the thing is, it may be a serious cut on the torso, or around the neck. Direct pressure is the answer. And even if a person is on blood thinners, Coumadin, for instance, they still have platelets, and it's platelets that coagulate the blood. So they still have platelets, and the blood will still coagulate. It's just that you're going to have to maintain pressure for perhaps longer before the blood coagulates, or you just don't release the pressure until you can get advanced medical care. The thing about pressure points is that unlike a tourniquet, a pressure point or direct pressure on a wound does not stop circulation entirely, because the capillaries are still providing circulation. There are more than one artery that even though you're trying to apply direct pressure on a wound or on a major artery, there are still other smaller, lesser arteries that are providing circulation. So that's one of the good things about direct pressure. But direct pressure, almost in all cases, will slow down the bleeding, and the platelets will eventually allow the blood to coagulate enough to help slow down the bleeding. You can just maintain the pressure, or you utilize pressure bandages, that sort of thing directly on the wound. So again, I want to emphasize how direct pressure works in almost every situation.
Thank you.
I don't want to get into, different scenarios or whatever, but it seems to me that if you're in a situation with a single victim, direct pressure makes sense if you don't have to address other, the other victims. But if you're in a situation where there are multiple victims and you have somebody who's, in the case that my classmate is talking about here, with somebody who's bleeding profusely because of whatever reason, it seems that a tourniquet would serve the purpose better because it allows you to move on and treat more people.
Well, it would, but you've got to have, you have to have the training for it. You have to be willing to
Right.
lose a limb in order to save a life. That you can, if the victim is conscious, they can apply direct pressure on
Themselves.
many wounds themselves.
Yeah.
If you've got a person who's been classified as minor that's helping you, they can apply direct pressure. There may be a victim near that victim that's bleeding, and they can apply direct pressure.
Right.
You have to be willing to think kind of outside the box,
Got it.
and so that you can move on and you can conduct triage.
Makes sense.
Anybody else? Okay, Jim, I'm going to stop recording.
All right, real good. Thank you very much, Mike.